So Dr. Perron actually introduced the next topic. I'm going to talk to you about predicting progression of ADPKD. And now we have a disease modifier therapy, tolvaptan, which Dr. Torres is going to talk more about that, which is has a significant impact in slowing PKD progression, but yet it is an expensive therapy, and it does have a number of notable side effects. So the question is, how do you pick the appropriate patient that are most likely to benefit from such a therapy? So that would be my next topic. So this is a genetic disease. So when we consider how to risk stratify patients, there are different approaches. One can look at clinical symptoms that may suggest faster progression or more severe disease. But in general, there are two major ways for consideration. One is to look at the mutation class, which I will cover. And then another approach is to look at the phenotype. The most appropriate would be the total kidney volume as a proxy of the cystic disease burden. So I'm just going to first cover the mutation-based prognostication. So this is a study that we did from Toronto, screening a large cohort of 220 families that we saw in clinic. And what we find using a comprehensive screening strategy for PKD1 and PKD2, that about 1/3 of the patients shown in the blue had a protein truncating PKD1 mutation. You have heard that this is likely going to be associated with a very severe disease outcome. On the other hand, about 1/4 of patients in the orange had a PKD2 mutation, which you have heard in the previous talk that are generally associated with mild disease. And in between, in the green and purple, PKD1 missense mutation or insertion deletion that does not alter the reading frame of the protein. They are kind of associated with intermediate outcome. And in our experience, 15% of the patient, we could not find a mutation. So this is a plot based on a larger number of patients, 780 from these 220 families, and including many of the older affected relatives, so that we could actually construct kidney survival plot shown on the left-hand side. And you can see that kidney survival in this case is defined as the need for starting dialysis or having a live transplant. What you can see is that the PKD1 protein truncating mutation shown in the blue line, the median survival is about age 55, which is a very well-known age cutoff that's described in most nephrology textbook. And in PKD2 patients shown in the orange line, the median age for starting dialysis or having a transplant is age 80. And in between, you have the green, which is the PKD1 missense mutation, and then the purple PKD1 insertion deletion that doesn't affect the reading frame. So they're kind of intermediate. And what is interesting is the gray line is the patient with no mutation detected, which I will also say a few words about it. They have, in general, an excellent kidney prognosis. So on average, we can describe groups of patients with different mutation class that seems to have very distinct prognostication. But in reality, applying this to the individual patient is very difficult. And this is illustrated by this familial study that we conducted. This is a study on the y-axis showing a subset of family members. Each vertical bar represents a family. A dot within the line is an affected relative in this family that had rich end-stage kidney disease. So not all the affected individual, but those who have already had rich end-stage kidney disease. So you can see using this hard outcome on the y-axis, there is a very significant spread on the age of starting dialysis within the same family. So the assumption is all these individuals carry the same familial mutation, yet the disease varies so much. So this nuance suggests a modifier effect, be it genetic or environmental or both. So it also makes it very difficult to use a mutation class to predict a single individual. The mutation class predict a group fairly well. That's the average effect. But when you want to apply to a single individual with high certainty, I don't think we are doing a very good job because of this modifier effect. And part of this modifier effect could be explained by some underlying complex genetic underpinning. For example, in this very large family that we studied many years ago from Newfoundland, there are two branches that have the blue bar and the red bar. They're all affected in this big family. But it turns out those who had the blue bar had a PKD1 missense mutation that are very mild, and those that had the red bar had a PKD2 mutation that are also very mild, as exemplified by the plot of the kidney function at the bottom between the blue dot and the red dot. You can't tell the age-related change in kidney function are very similar. But there were two individuals in the green at the bottom. They carry both mutation, and the disease seemed to be more accentuated, and they do worse than individuals that carry only one of the familial mutations. So this is an example of genetic interaction. It's kind of a fluke of the nature's experiment in human that result in individual in some family having more severe disease because they are carrying additional genetic burden that are not recognized. This is another example of a genetic interaction in a young baby that was diagnosed in utero to have polycystic kidney before birth, and it turns out that the father had a PKD1 truncating mutation. The mother had a PKD2 mutation. They marry by chance, and he unfortunately inherited both mutations. So he had more severe disease that presented like even before he was born, and so he would be expected to have more severe disease than either parent. We also recognize that there are also more nuances, and this is an example of a allelic interaction, like PKD in families that had more than one PKD1 mutations. In this case, on the left side is a family in which the light blue bar denotes individual that carry a PKD1 indel mutation, and the father shown in this pedigree actually had very mild disease, had developed ESRD at age 76, and then the mother was not thought to be affected, but they have 5 children and all 5 affected, which is highly unusual for a autosomal dominant family. So when we did further analysis, it turns out 3 of the 5 carry this light blue bar that denote the mutation inherited from the father. But what was unrecognized is the mother also carry a missense PKD1 mutation that was transmitted to 3 other children. And one of the children that carry both had much more severe disease and appeared to develop end-stage kidney disease prematurely in her 20s. So these are examples that you may have an additive effect in this kind of unusual individuals. And then the family on the right is an individual that presented to us with end-stage kidney disease at age 44. And she was found to have 2 PKD1 mutation, The one that was associated with the light blue bar is a PKD1 missense mutation that she inherited from the father, who had been thought to have simple cysts, and he is doing quite well in his 80s. But the patient herself also acquired a de novo mutation that is associated with this dark blue bar that is inherited from the mother. The mother does not have the mutation, but she had the de novo protein truncating PKD1 mutation. And in combination, she had seems to be a more severe kidney disease requiring dialysis at age 44. So these are kind of example of the complexity that may affect a small percentage of patients that result in familial within family variability. One other interesting phenomenon is this somatic mosaicism. So far, we are very familiar with ADPKD, in which the disease is passed on to the offspring from one affected parent. But in somatic mosaic individual, both parents are unaffected, but the individual acquire a de novo PKD mutation during early embryo development. So during this stage of the human development, all these cells are polypotent stem cells that eventually give rise to the trillions of cells that make up of our body, organ, and tissue. And only one of multiple of these stem cells were acquired of this mutation. So you could envisage this kind of individual having a diluted disease, and that's why they are called mosaic. And so these individuals actually do happen in ADPKD. We are increasingly recognizing them. And in some of the patients that I show you in this gray bar that we didn't find any mutation, they fit this description. No family history in parents, and they may also have some atypical imaging pattern, and that is in the Mayo Clinic imaging classification. So in this individual, as an example, she presented to us with asymmetrical polycystic kidney. The left kidney is a lot bigger than the right, with many bigger cysts. And the right kidney have relatively mild disease at age 55. Her height adjusted total kidney volume was 530 ml per minute. What is intriguing and unusual in this individual is that she has an affected daughter. Most of the mosaic individual, there's no affected offspring, and we can talk about why. But in this case, her daughter, 19, definitively affected with the same height-adjusted total kidney volume as the mother, although they are 3 decades apart in the age, suggesting her disease is much more severe. And what is interesting is in the daughter, this is a DNA tracing showing double peaks. So this individual had one base pair deletion, resulting in a frame shift in the PKD1 gene. In the daughter, the DNA sequencing tracing is unambiguous. In the mother, on the other hand, it shows very low amplitude of changes. Sometimes can be passed off as a PCR artifact, but in this case, it is really a true reflection of a mutation. And on the quantitative analysis of the two alleles shown in the right panel, the daughter, both the mutant and wild type peak are very similar in copy number, but in the mother, the mutant peak is only about 1/10 of the normal copy. So her disease is diluted, and as reflected by the DNA in the white cell in which we do the sequencing. And you can envisage the same thing happening in the different tissue, and therefore giving rise to this kind of atypical presentation. So we also recognize, I show you the modifier effect tend to make the disease worse. But what was interesting to us was observation when we have imaging and genetic and we see patient as a recognition that some PKD1 protein truncating mutation may be associated with very mild disease. Because we do mutation and imaging together in all patients in a clinic, so we often would say, well, look at the image and predict the mutation. And then we recognize that we make some mistakes in some of these. We know that the patient have a PKD1 protein truncating mutation, so we expect more severe disease, and we don't see that. Then we say, oh, did somebody make a mistake, like in a patient ID or mix up? When we went back, we realized this is real, and then we start to look systematically. And what we find is that in this large cohort of patients that we have been following, we have close to 2,000 patients from about 600 pedigree we have studied. About 570 we know had a PKD1 protein truncating mutation. At the time of publication of this patient, about 500 had MRI imaging, so we know the Mayo Clinic imaging class, as Dr. Perron had already mentioned, 1C, 1D, 1E associated with severe disease. So we would normally expect this group of patients to be in that category. And yet, what we find is that there are patients with the PKD1 protein truncating mutation who are in the 1A, 1B category. So to our surprise, this is somewhat unexpected. And so these are some of the imaging patterns of the patients. So the top panel showed these kind of PKD1 protein truncating mutation with mild disease and the age of the affected individual. The two examples are age 36 and 46. The middle panel, PKD1 protein truncating mutation with the more typical severe disease that you would expect. So adjusting for the age, this is what they look like. And then the bottom panel, similar age individual who have PKD2 mutation. So you can see some of these individuals really have very mild disease that we don't expect. And so and then we kind of plot them looking at the larger group and looking at the individual with the mild disease and PKD1 mutation in the light blue line, they have a kind of a milder expansion of the kidney, very similar to the orange line, which is the age and adjusted PKD2 mutation individuals, or a lesser decline in their EGFR. So like these patients seem to have milder disease than one would anticipate. And then this is showing the within family variability of these individuals, or each of the family had at least one of these unusual individuals. The black dots are those who had end-stage kidney disease, which we kind of expected in their 50s. But there are individuals that are older than 50 or in the middle age that had the Mayo Clinic 1A, 1B as shown in the light blue open circle. So there are definitely some of the older individuals that seem to be discordant to their affected relative, but in a way that is not severe disease discordant, but milder disease. So taken together, this kind of within family disease variability suggests to us that the modified effect not only can make the disease worse, but in some instances, it could actually be protective. And if we could understand this protective factor, it may give some insight of potential therapy. I didn't have time to go into that, but Terry mentioned about the Somlo experiment, about the cilia targeting and defect with PKD1 actually unexpectedly make the PKD1 disease milder rather than severe. So I think that it would be very interesting, and we are doing a study to look at exome sequencing of this individual, like looking at whether they carry some kind of ciliary gene that turn out to be protective rather than deleterious. I think that may be very interesting. So because of this intrafamilial variability and the presence of a modifier effect, I think that we cannot use genetics to predict the disease severity in an individual patient. And this is a kind of current indication of using genetics. I think most of the time we don't really need the genetics because you can diagnose someone and we can prognosticate using imaging approach. There are some instances that genetic testing may be helpful, and they include family that have no apparent family history or with equivocal imaging finding, or individual who are going to be considered as a living donor, but they are relatively young, and you can do imaging, but even MRI showing no cysts. If they want more confidence and they have an affected family member that with a known mutation, we can provide further evidence of exclusion by doing familial testing. And then prenatal or pre-implantational genetic diagnosis would also be another indication. There's also a number of potential evolving indications as we now progress to more sophisticated testing, and this include high-risk individual for novel therapy in clinical trial, but we are not there yet, as I mentioned, because of the intra-family variability. Patient with atypical presentation, either very early or severe disease or discordance of disease within family, or unusual, asymmetrical, or lopsided. These are so-called atypical pattern. It may be possible to do genetic testing to define whether they are potential mosaic individual, but it requires very sophisticated next generation based type of sequencing, not the usual Sanger-based sequencing. And of course, lastly, the syndromic form of polycystic kidney disease that is not ADPKD. I think genetic testing would be relevant. So I think this is a way to go. Next generation sequencing, we are now using a gene panel approach, looking at other disease, a potential modifier, as well as ADPKD for screening. But this is more for research testing. So I'd like to kind of go to imaging for prognostication. And as you have heard from the CHRIS study, we have learned that kidney volume expand on average about 5 years, 5% per year during the adult life of individual, while the kidney function can remain stable for several decades for many patients and only decline at really severe disease at the end. And so kidney volume has been confirmed as a reasonable biomarker of disease severity. I do want to point out that in the CHRIS study, even going to, I think, year 8, total kidney volume only explained about 40% of the variance of the eGFR decline. So total kidney volume, while useful, does not explain and does not capture all the information. I think the next generation sequencing that imaging, actually, Dr. Klein will be talking about, may potentially help to improve our prognostication. You have heard about Dr. Perron mentioning the Mayo Clinic imaging classification by Dr. Torres' team, which is widely used, and then I think that the class 1A, B, C, D, E subclassification give distinct prognostication. Again, this is looking at average of a group of patients, but nonetheless, it is helpful, and you could kind of combine maybe the groups like CDE as potentially individual who would benefit from tolvaptan therapy, whereas 1A, 1B had much milder disease and generally have excellent prognosis that may be reasonably managed with conservative management. One important point is that it is important to, when you use this classification, make sure that you exclude the atypical cases because they are not applicable in this kind of setting when you have asymmetric or unilateral polycystic or segmental cystic disease or lopsided pattern. Many of these individuals may in fact turn out to be somatic mosaic, and because of the presence of largely normal parenchyma, that's the reason why they won't need dialysis. So they have a very distinct prognostication and doesn't really require a lot of intervention. In the class 2 disease, there's also another pattern that are associated with small kidneys with some cysts, and they may be related to ischemic changes or other unusual forms of other genetic cystic kidney disease. So in our own experience of a large cohort that we kind of look at this systematically, we find about 7% of our patients have the class 2 pattern, in which we should not use the Mayo Clinic imaging classification for prediction of disease progression. So a common question asked is, can we use ultrasound to predict, to derive total kidney volume and use it for the Mayo Clinic prognostication? So we did a study to compare the two different ultrasound method, that is versus MRI methodology to calculate kidney volume and for Mayo Clinic classification. And to try to derive some data. So in 142 patients, and including a spectrum of Mayo Clinic imaging class 1A, 1B, 1C, not so many in the 1D and 1E group. And what we find in the, I guess this would be the, depending on where you are on the far panel, is the comparing pairwise performance or actually difference in the total kidney volume and between MRI using an ellipsoid model, like measuring the 3 orthogonal axes versus manual segmentation, that is tracing each slice individually and adding it up, which is a gold standard for measuring accurate kidney volume. And you can see both methods about the line, the red and the blue line, approximately at the 0% difference, indicating that no significant bias. Whereas when you look at the comparison between ultrasound using an ellipsoid method, and then there's another technology called 3D ultrasound for kidney volume measurement. There's a systematic bias in ultrasound underestimating the kidney volume as measured by the gold standard MRI. So by about 10%. And because of this bias, when ultrasound, using ultrasound total kidney volume in the Mayo Clinic imaging class, if it predicts a large kidney, it's unlikely to be a mistake because of this underestimation bias. So ultrasound prediction of the 1C, 1D, 1E is highly accurate using either the ellipsoid or the 3D ultrasound, but not for predicting the smaller category. So this is just showing the kind of a positive predictive value of using the ultrasound ellipsoid and 3D ultrasound compared to MRI ellipsoid. And so the positive predictive value is really very similar to the MRI ellipsoid, although the sensitivity is less comparing to the ultrasound method. The problem using an ultrasound method is that you still need to exclude the class 2 cases. So then unless you have a good way to recognize the ultrasound pattern for the class 2 cases, there will be some mistakes because of that. So this is something that one need to be aware of. So one last thing I want to point out is having the availability of imaging and genetics actually allow us to actually learn some of the more nuances of disease progression and variability. And this is because we have a lot of information on both the genetic, the mutation class, and also the kidney volume measurement. And so this is just one example I want to show you. That is when you have imaging, because there is proposal by the European group of just using the kidney function as a surrogate of disease severity, either an age-adjusted eGFR or the slope of decline, to identify high-risk group for tolvaptan therapy. But the problem, I think, potentially is that there is one group of patients, as shown here in the left bottom quadrant, and these are individuals who do not have large kidney volume and who have low eGFR. Okay, so the question is, why do they have, if they have bad polycystic kidney disease, why is that not reflected by the total kidney volume? So we try to look at this group of patients. About 30% of them, the eGFR was less, but these are large muscular individual patients. And when we did measure creatinine clearance is generally over 100. So when you have large muscular individual, the creatinine is higher, and you use eGFR, that is not reliable in actually predicting the true kidney function. There's another subgroup of individual in this category, and they have a second disease, diabetic nephropathy, GN, renal vascular disease. And I would add, actually, relatively commonly is some of them, when we do the genetics, well, they may have other forms of genetic kidney disease, which are rare. But with one exception, that is, there are a number of individuals who have this call for A3, A4 variant, and they are essentially carrier of a recessive Alport syndrome that is relatively common in this carrier state in the general population. And clinically, typically, they would have thin basement membrane disease or so-called benign hematuria. But in combination with PKD, they can do not as well, and the kidney function may decline more than expected. So I think these nuances need to be recognized if one is going to use the eGFR only way to kind of prognosticate. And the question is, it is not so easy to recognize that if you don't have an imaging to tell you that there's some discordance going on, like between the eGFR and the expected cystic disease. So in conclusion, I would suggest that the risk assessment in ADPKD is an evolving process, and then it will be refined by newer clinical data and test technology. And currently, I think the Mayo Clinic imaging classification is likely providing the best single kind of risk assessment tool that is relatively simple and easy to use. Gene-based testing is less reliable at the level of the individual patient due to the presence of a significant modifier effect. And I think the performance of risk assessment methods need to be evaluated and validated by real-life clinical data. So I think I will end, and then I think I have the two quizzes. Okay, so the first question. So there are PKD1, PKD2 mutation class provide. There are 5 choices. First, highly accurate risk prediction for individual patients. Second, average risk prediction for different groups of patients. Third, cannot be used reliable for clinical risk prediction. The fourth one, all of the above. Fifth, 2 and 3 are correct. Okay, can we show the results, please? Okay, so it should be the 5th one. Okay, I'm not doing a very good job. Okay, all right. So can we just go back? I just wonder. Oh, sorry. So yes, so it is true that you cannot reliably, uh, but it is also accurate in predicting different groups of patients, average. So it's really 2 and 3 are correct. That's why it's number 5. Huh?
There's only one person participating in the poll.
Oh, okay. All right. All right. Okay. All right. Sorry. Okay. I'll give you more time next time. Okay. Okay. All right. Yeah. So the correct answer is number 5. Yeah. Okay. Can we go back to the, okay, go to the next quiz. Okay. So total kidney volume in ADPKD, 5 choices. One is to provide a proxy of kidney cyst burden. Number 2, Mayo Clinic imaging class adjusted for total kidney volume by age and height provides a measure of PKD severity. 3, Mayo Clinic imaging class should not be applied in patients with atypical PKD kidney imaging pattern. 4, 1 and 2 are correct. 5, 1, 2, and 3 are correct. Okay, can we have the answer, please? Okay, you're waiting still? Okay. Okay, so number 5 is correct. Okay, so this concludes the first segment of the presentation today. So we have a coffee break for about 20 minutes. And I want to just remind everybody, if you have questions, please enter in the chat box